Jeff just helped me out. He said dead ears don't hear. And I mean that's a great way to look at it. So if the complaint is, you know, I can't hear out of my right ear, and the Weber goes to that side, then that's comforting. If it goes to the opposite side of the complaint, then that's like, huh, how did that go again? You know, probably there's a problem there. So this is the last thing that we'll talk about. So this is this great problem of dizziness and vertigo. So this is a very difficult lecture to give because we have to, you know, mash through definitions of how things go. So I think, you know, Nikki, how many dizzy patients did you see in the medicine clinic?
All the time.
All the time.
Oh, I just turned to Jeff and I was like, I hated dizzy patients.
Right.
There's so many reasons they can be dizzy.
Right. So there's so many reasons that you can be dizzy, and hardly any of them have to do with the ear.
Right.
So remember that. But we'll talk about the ones that, you know, are distinctly from the ear, so that you can you know, kind of help go through that. So the inner ear has two jobs. Its first job is to hear. The other job is to understand what acceleration forces you are under. So you have two sets of acceleration detectors. You have the ability to detect linear acceleration, and you have the ability to detect rotational acceleration. So this is a picture of the inner ear. This is a picture of the picture that hangs in our office. We'll kind of go through each of these structures to maybe help you understand what and how we can make this better. Yes?
Can I ask an anatomy question?
Yes.
So we learned yesterday in physiology about the saccule and the
Utricle?
yeah, but where are they?
Yeah.
Because 2D pictures don't really help.
Yeah, they don't. So the utricle and the saccule are. How come I can see it?
Yeah, push it over.
Keep going.
There Very nice.
Oh boy, my kids. I have 5 kids. They would just love this. They would love this moment right now. Okay, so here's the eardrum. Okay, so first hearing bone, second hearing bone, third hearing bone, hammer, anvil, stirrup. Yes, they all look like that. And then at the base of the stapes is the foot plate. In the foot plate, underneath the foot plate, is a place called the vestibule. Vestibule means little entry place. So in the vestibule are 2 recesses for the utricle and the saccule. I'll show you a better picture in a minute. But they are in here. Okay? So here are your semicircular canals. This is the superior semicircular canal, posterior semicircular canal, and horizontal canal. And then this is your cochlea. The other big point that I want you to remember is that every facial nerve paralysis. What do you guys left?
I said it looks like a teddy bear on its side.
I wish I had as much.
Can you see it?
I can see it.
See it? Yeah, like there's his eye and his little butt nose.
No, let's go. Okay. So one of the there are 4 nerves. There are 4 nerves in the internal auditory canal. There are 2 balance nerves, a hearing nerve, and the facial nerve. Okay? Where does your facial nerve come out of the skull?
Internal acoustic
We know where
So the facial nerve comes out at the stylomastoid foramen.
There it is.
Underneath the mastoid, near the styloid process. Okay? So it's right in here. Okay? Deep. Underneath your parotid. Deep. But it goes through your middle ear. Okay? So every facial nerve paralysis is not labeled Bell's palsy. You only get to call it Bell's palsy after you've eliminated everything else. So that is a diagnosis of elimination, not the first thing that you say. So the child with a facial nerve weakness and an ear infection needs what?
Oh, come on, we talked about this.
Tube, yes. Yes, needs a tube. Needs a tube. Because you have to remember that what do we call, I mean, what category of nerve is the seventh nerve? It's a cranial nerve. Good job. Where do those cranial nerves come from? Brain. Yes. And if you have an infection, if you have an infection affecting a cranial nerve, that's bad. That's a bad thing. Okay. So remember that. You remember I jokingly said, if anybody asks you, in a snarky way, well, why are you going to give antibiotics to that child, right? So meningitis, brain abscess, and death are reasonable reasons to give those things. So the middle ear space has connections to the brain. So remember that. One of those connections is through the facial nerve. So facial nerve, Bell's palsy, diagnosis of elimination. Not the first thing that comes to your mind.
Can I ask one more?
Yes.
And then I'll be done with my
No, this is good. This is better than me talking
So
about
there's
dizziness.
So there's two middle ear auditory muscles, the tensor tympani and the stapedius.
Yes.
And it says that it's attached on the malleus and contracts from the tympanic membrane. Like where, is it literally just on the
Yeah, it's
malleus?
not visualized in this. Not visualized in this. The tendon is not visualized. So here's the Eustachian tube, right there. The tensor tympani muscle comes up the Eustachian tube, forms a tendon, and then above the it goes from this position here to the neck of the malleus to make its connection. So this is not to size, and so we had to take some poetic license to, eliminate some things. So yeah, so the stapedial muscle goes right here, and it is innervated by the facial nerve. So two of the smallest muscles in the body. You bet. Okay, so dizziness. Patient comes in and they say, "I'm dizzy." So dizziness has absolutely no meaning. So dizziness is whatever you say it is. So we ask the patient, we now have a form that says, define your dizziness, so that you and I are speaking the same language. Vertigo has a very specific definition, and that's the illusion of movement when there's no movement. And what that means is that there is some stimulation of the inner ear causing you to feel like there is movement, causing you to feel like there is some acceleration force. Balance is the integration of a massive amount of information from the tips of your toes all the way to the top of your head through every nerve, joint that you have, every corpuscle, Pacinian corpuscle that you have to tell you where your body is in space. Integrated with the information of the acceleration sensors in your ear, married to the information that you're getting through your eyeballs. Okay? So, if I turned around and we all watched the train that is the back wall, and we were all standing up, and we're all watching the train, and the train starts to go like this, we're all together going to go like this. until we realize, oh. That's moving, but nothing else is moving. I'm going to go back like this to maintain balance. So your visual field has super duper preference over what's going on. So much so that one of the first things that they, anybody a pilot? You solo it. Okay. So you have your VFR, right? But you don't have your instrument rating. Okay. So when you go, so why do you only have your VFR, Visual Flight Rule Pilot certification? Why do you only have your Visual Flight Rule certification?
Because the instrument is like a whole extra tricky.
It's a whole extra thing. And you can only fly when what?
I can see.
When you can,
and everything around me.
yeah, when you can actually see the horizon. Yeah, so she can only fly when she can see the horizon. Because if you can't see the horizon, you can't tell up from down. So, scuba diving accidents, lots of people swim down. And the reason is because there's no gravity to tell you which way is up. So, balance is the exact and perfect integration of visual, proprioceptive, and vestibular system about where the head and body are in space. We'll get back to more flying examples here in a second. When that's out of whack, people say, I'm dizzy. And they'll say all sorts of things. So, like, I'm lightheaded, I'm not right, it just feels weird, they'll say all sorts of things. Your job is to determine when exactly are you dizzy. If they say, I'm dizzy when I stand up too fast, then that's probably a medication problem or the fact that they have lots of fire on their birthday cake and they need to stand up slower. Or, did you not? People pay me every day to tell them this. Or it's an indication that they have replaced their ankle, knee, hip, had 35 back surgeries with rods, neck surgery, and their body just can't tell where they are in space. Okay, so the vestibular anatomy is confined to up here in the head, with some spinal pathways that connect as well. I said previously in flying, visual is most important. Now I'm going to reverse that. I'm going to tell you which system is actually more powerful. So let's all play a game. These are the things. These are the only things that are ever remembered. So here we go. All right, so let's play a game. So everybody, put your finger out here. All right. Take your head and shake it back and forth as fast as you can, and go faster and faster until your finger becomes blurry. Okay? All right. Everybody dizzy? Okay. So now, lock that velocity, how fast I can move my head in your mind. Take your finger now and move your finger back and forth as fast as you can. And which one is faster?
My finger.
What can you move? What can you move faster? Before it gets blurry. Anybody who said that they can move their finger faster needs a neurologic exam. Okay, so the right answer is that you can move your head faster than you can move your finger, because your inner ear is hardwired, not really in a reflex arc, but they call it a reflex, not really in a reflex arc, to your eyeballs. So when you move your head like this, your eyeballs maintain a stable visual field automatically. That's called the vestibular ocular reflex. So I can move your eyeballs without you wanting to move your eyeballs. Yeah, I can. And I can do that by injecting hot or cold water in your ear, which affects the horizontal semicircular canal and causes that fluid to move inside the semicircular canal, which moves the ampulla, physically moves the ampulla connected to that horizontal semicircular canal, which causes a neural impulse to go from the ampulla straight to your eyeball, and your eyeball will go over there because it's hardwired to do so. So if you have a vestibular problem, if you have a vestibular insult, you will have this thing called nystagmus. Okay? So what is nystagmus? Yeah, it's eye movement that you can't control, and you name it by the fast phase of where it goes. So if the eyes are fast going to the left, then you call it left beating nystagmus. So how can you induce nystagmus at home? Right, if we took that chair and taped you to it and spun you around and then stopped you, or if we played Dizzy Bat, I thought about playing Dizzy Bat today. So if we spun you around and then we held your head still, you'll see the eyes beat in one direction depending on which way you spin. And they do that because your inner ear has fluid that is moving in it, that is moving your eyeballs. And that whole reason for moving your eyeballs is to maintain a stable visual field. So here's a picture, just a stylized picture of where the utricle and the saccule are and the horizontal semicircular canals. We talked about that. We're going to skip over the fluids. You have fluid in your inner ear. Okay? You can affect that fluid in your inner ear, and I'll tell you how in a little bit. Okay, so physical movement of that fluid causes you to feel accelerations. So when you are spinning around in the chair and you stop, that fluid is still moving and still exerting force on the sensory cells to cause an electrical discharge to cause you to feel like you're moving and to move your eyes in the same way. So somebody comes in and they say, I am so absolutely dizzy that I can't stand up. You're going to look at their eyeballs and you're going to look and see if they have nystagmus. If they have nystagmus, your suspicion that there's an inner ear problem will go up. If there's no nystagmus, then it's probably not an inner ear problem. Could be a stroke. One of the, I dread every time I see one of those commercials like signs of a stroke, dizziness. I'm like, oh gosh. It's true, but unfortunate. Okay, so you have 3 semicircular canals which sense rotation. The best understanding of how those canals are oriented is to look at the corner of a room. So if I'm looking at that back corner, the ceiling is the horizontal canal, and then one wall is the posterior canal, and one wall is the superior canal. The horizontal canal connects to the vestibule all by itself, so it has a non-ampulated end and an ampulated end. The posterior canal and the superior canal share a common joining spot, and we call that the common crus. And that has some implications for a disorder that we'll talk about here in a second. They are not, so the horizontal canal is not horizontal, it has an angle, and the reason that it has a 30-degree up angle is that in a normal position, you cannot move your head in any direction without stimulating 2 canals. So there's a large amount of redundancy in the system. Okay, so this is a CT scan of the temporal bone. This is a coronal view, so it's up and down through the skull. I put this in here just so that you can see that these are not like links, rarely seen, or like other people besides Dr. Netter can see these things. So here's the internal auditory canal paralleling the external auditory canal. This is the superior semicircular canal. Here's the horizontal semicircular canal. Here's the cochlea. Here's the hearing bones. This is the mastoid. So we can actually see these things. Okay, so head motion causes flow of fluid, which causes the sensation of motion, which moves your eyeballs. Okay, so here's our question for where is the utricle and the saccule. So we're back to the, this is from a book from like the 60s. They used to do, they would do stapedectomy with a drill. And they would take a 1.3 millimeter diamond burr, and they would go through the foot plate. And beneath the foot plate, 1.25 millimeters deep into the vestibule is where the saccule lives, and then on almost the opposite wall is the utricle. And these linear acceleration sensors are oriented at a 90-degree plane so that you can't move in any direction in an acceleration sense and not stimulate those organs. So there's a large amount of redundancy, and the space is really tight. Okay, so otolithic organs have crystals, calcium carbonate crystals that make up this otolithic membrane. You have cells, hair cells that are embedded in this otolithic membrane, and this floats in a perilymph bathing fluid that perfectly suspends the utricle and the saccule so that they're under no tension, as long as there's no motion. So, can anybody tell me the linear acceleration that we're always under? Gravity, right. And we need that. We need that. So we're always under the sense of gravity. So the saccule is oriented in a vertical plane. The utricle is oriented in a horizontal plane. Now that I'm saying that, I'm questioning if that's true, but nobody cares besides me. But anyway, so there are crystals or rocks that are a part of these otolithic membranes. There is a disorder where a portion of the otolithic membrane can be fractured off, and the rocks can get lost inside the semicircular canals, and you can feel motion when there is no motion. And when we feel motion and there's no real motion, what do we call that? Vertigo. Very good. And so we're going to skip to we'll come back through this. Okay, so when we have these rocks that can break off of the utricle and the saccule, and they can get lost inside the canals, you can have vertigo, which lasts for just a few seconds, that is provoked by position and some motion. Usually it's looking down or looking up, but usually it's a position, lying down, rolling over in bed. So the patient will say, when I lie down, my world spins for less than a minute, and then I might feel really weird for the rest of the day, but I have this position-provoked vertigo. And so you lie down, roll over, look up. Short episodes, not usually associated with nausea and vomiting and lots of unhappiness. We'll do the Dix-Hallpike maneuver. Does that ring any bells from a neurology lecture or something like that? Okay. So Dix-Hallpike is we have chairs and ear, nose, and throat, and so lay the chair back, take the patient's head firmly in our hands, because when somebody experiences vertigo, they're like, I don't know what's up, the direction of up. So take them back, hang their head, hold them there, watch their eyes, and if they have BPPV, benign paroxysmal positional vertigo, then the eyeballs will beat towards the ground as long as the rocks are moving. So the rocks are falling through the semicircular canal because they get lost in the semicircular canal, fall through the semicircular canal, and cause the vertigo. Once the rocks stop falling, then the vertigo will stop, and you will see the nystagmus stop, and you'll be able to tell the patient, yeah, I see that you're not spinning anymore. And they're like, how do you know that? Then you set them up and tell them that, okay, you're going to feel the same thing because the rocks are going to go back the other direction. You're going to feel another sense. And then when you put them down again, the vertigo will be less, the nystagmus will be less because there's less rocks. And the more you position them, the less and less the symptoms will be because the rocks are distributing themselves across the posterior semicircular canal. And the treatment for that is a thing called the Epley maneuver. And the Epley maneuver is basically rolling the patient around through the arcs of the posterior semicircular canal to put the rocks back in the same place. But it probably is the best example of how rocks, or how the a disorder of the semicircular canal is connected to the eyeballs. So if you have a complaint of vertigo, sensation of motion, and you can elicit nystagmus, it gives good information that this might actually be an inner ear disorder. Okay. So, nystagmus, we'll just go through this real quick. So it's a reflexive eye movement. It's not something that can be controlled. So it has a fast component and a slow component. We named it by the fast part. You can suppress it after the fluid stops moving really fast. So in our neurology class, my neurology class, remember that we say that it goes cold, opposite, warm, the same. Did that ever register with anybody? Okay. So if you take hot or cold water, you can inject cold water in the ear, and you can elicit this nystagmus, and you can see the nystagmus move. These are slow phases. Cold moves to the opposite ear in the slow phase, and warm moves towards the same. If you ever work in an intensive care unit, work in the trauma unit, where you're going to do death tests, see if there's absence of brain function, cold water stimulation to see if there's any nystagmus present is part of that test. Again, because you can't suppress it. It can't be suppressed. It's not unless the patient is paralyzed. So, if there is vestibular loss, so if there is vestibular loss, there's something wrong with the inner ear. You're going to have nystagmus. You're going to have nausea and vomiting. Why is there nausea and vomiting? Because your inner ear is hardwired to not only the eyeballs, but also this place in the brain called the nausea center. That space may have been accessed through this mechanism of a vestibular loss that some people might indulge on, maybe to tailgate or something like that. We'll talk about those in self-induced vestibular deficits here in a minute, which is the second thing that people remember besides the shaking of the head. So what do we do? So, ask the patient to define their dizziness, review their medications. If they're on 4 beta blockers and they say that I'm dizzy when I stand up, that's probably the cause of their dizziness. We see a tremendous amount of polypharmacy with heart medications. And I'm really not quite certain what the actual use of gabapentin is anymore. I mean, because it seems like everybody's on gabapentin. Why are you on gabapentin? Well, okay. Those are all centrally acting medications. So gabapentin affects your brain, and if you're affecting the computer processor that is supposed to be processing all of this information from your toes to the top of your head, integrating your visual information and your inner ear, some of these medications could have overlay. So, and then lots of, how serious is this? I mean, are you affected on a daily basis, every minute basis? How serious is this for you? So we want to know, just all the standard questions of when it came, when it started, how does it go, are there nausea, vomiting, fever? Is there any hearing loss with your symptoms? Do you have headache? When I went to medical school, migraine headache was like a thin book on the shelf. Now migraine headache is like an entire shelf. I mean, the definition of all the different kinds of headaches that can be present is just immense. With that, we have an emerging understanding of something called migraine-associated dizziness, MAD, or migraine-associated vertigo, and it can mimic many, many, many things. So one of the first things that we really encourage folks to do is that in the process of let's figure out what your vestibular disorder is, why don't you go to a neurologist and get absolute control over your migraine headaches. And a vast majority of those patients, once they get control over migraine headaches, are really helped by their dizziness and vertigo symptoms. So physical examination. It is really helpful to see people walk. So because this is a Thursday afternoon, nobody probably has on some stiletto heels now, but you know, when the 32-year-old lady with you know, car carrier on one side, you know, diaper bag and mega purse on the other, she comes in with her high heels on, like, yeah, you're dizzy, your balance is great. And the reason for that is that, you know, any elevation of your center of mass off of the floor is really quite an amazing thing. So watching them walk, Romberg, you know, just seeing how good their balance is. You know, what are they able to do? Did you demonstrate a Fukuda?
No.
A Fukuda form? So a Fukuda test is like a moving Romberg. So inside your vestibular system, it's always working. It's always looking for accelerations. And when you're in, it's always looking for accelerations. So if you have a deficit between one side to the other side, like a vestibular disorder would give you, if you ask the patient to assume a Romberg position and march, then you are implying to them, I want you to march, I want you to stay in this direction. If you take away their visual fixation and there is a deficit on the left side, they will rotate to the left because their world is rotating to the left, and then they will open their eyes and go, wow, what happened?
True.
True, okay. So, you know, a Fukuda stepping test, you usually have them go 50 steps. And if they're like, you know, like this, you know, that's probably a different neurologic problem, you know, cerebellum, brainstem issue. But very, very helpful to pick out if there's something wrong with the vestibular system. Coupled with this is an audiogram. So we use audiograms quite frequently. Okay, so some specific things. Vestibular neuritis. So these people usually show up to the emergency departments and they're like, I am, you know, I'm having such severe vertigo. I can't walk to the bathroom. I am crawling to the bathroom. I am crawling in. I'm throwing up. I don't have a stroke. I'm perfectly intact. I wish I had a stroke so that I could, you know, go to sleep and be relieved of this. They're perfectly intact. No hearing symptoms. That's the picture of a vestibular neuritis. These are people that we would give some high-dose steroids to. This is a very rare thing, so just know that just like this is the Bell's palsy of the balance system. So just like a virus can affect the facial nerve, a virus can affect the vestibular nerve, and you can have this acute vestibular crisis. They feel awful for 3 days and then slowly get better over several weeks. So we talked about BPD. Okay, so everybody in the world who comes to our clinic says that they have Veneers disease. In reality, probably less than 1% of the folks who come in for Meniere's disease actually have it. And so the hallmark symptoms of Dr. Meniere, French neurologist who described this in leukemic patients who were hemorrhaging into their inner ear. They didn't really have this, but that's what he described. They will have recurrent bouts of vertigo. These vertigo episodes will last for hours, 45 minutes, 12 hours, awful. Hearing loss, ear fullness, and ringing in the ear. They might have Meniere's. We see these folks, get a hearing test, document their fluctuation of hearing, see them back over long periods of time. The most helpful thing for a Meniere patient is a low salt diet. So salt, mismanagement of salt in the inner ear is tightly tied to a true Meniere patient. If we were going to, do a comprehensive course over inner ear anatomy, we would go through the micropathologic makeup of the stria vascularis, which is like the workhorse engine of the cochlea. And it has many characteristics that are associated with the kidney. So there are many ear problems and kidney problems which kind of mimic one another, and there are even some syndromes that have the names otorenal associated with them. So Meniere's is very rare. And for those folks, on the long-term management, we give Valium to put them to sleep for their spells, and then we tell them to get up, get out, and adapt and compensate after their spell is over. So Valium and Zofran to help them make it through these awful periods. But mostly it's just supportive. There are some surgical options. I try not to operate on these folks. I try to really just manage them medically. I think pretty good. Multi-sensory function. I had an anesthesiologist ask me if I would see her mom. She had an acoustic neuroma at one point in time. She's been diagnosed with Parkinson's. She's and she's dizzy. She's just feeling awful. She's on a ton of medications. She said, "Well, what can we do for her?" I said, "Well, we can get her connected to physical therapy." So most balance problems and vestibular problems are really helped by going to see a physical therapist. We call it, in the clinic, we call it ballerina school, because ballerinas are trained. They're not born. I mean, they are trained. The ability to spin around and do all those things, it's all training. So we can take you to physical therapy and have you adapt and compensate for the new wiring diagram that your brain and brainstem are declining through. So, you know this. In school, you stop moving, you stop exercising, you start sitting more, and then when you start to try to go do something, you're like, oh my gosh, I feel terrible. Well, part of that reason is because we all, function on the basis of move it or lose it. Migraine, yeah, get your migraines fixed. Psychiatric disorders, the patient will say, I'm always having vertigo. I never have any fluctuation. It's constant. There's nothing I can do about it. So we treat their I don't treat their psychiatric stuff, but send them off to get their psychiatric stuff treated, and they usually do much better. Acoustic neuroma, yeah, you have a mass growing on your balance nerve, but it doesn't cause any symptoms because you slowly lose function at a pace where you're able to adapt over time. Okay. We used to send people to Caroline Craven, who is one of the greatest humans on earth. She retired. Gosh. So now we send lots of folks to the Jim Thorpe Balance Center. Okay. So the last story that you'll remember, self-induced vestibular crisis. So I told you that there's fluid in your inner ear, and that this fluid is bathing these inner ear structures. So after this lecture, maybe Jeff and I will start early. After this lecture, we might go have a beer. And the beer, the alcohol, will diffuse through your system, and it will diffuse into the inner ear. So it will diffuse into the inner ear such that your brain, which is expecting certain movements to equal certain stimulation, sort of like, when you changed from my, 1982 IBM computer to an Apple computer, and the P is just a little different because that's what Apple does. You couldn't find the P for a while, but you adapted. So your brain is expecting certain things at all times. So you add a little alcohol to your inner ear, and suddenly this movement is not equaling the neural stimulation that your eyeballs and your neck are processing into your brain. And you have a visual vestibular mismatch and a neural vestibular mismatch, and you feel what?